Hello and good afternoon, clinical clerk. Today I'm going to start with cholecystitis. Again, my reference is Tintinalli's Emergency Medicine with a few adlibs here and there. Let's begin. Cholecystitis is inflammation of the gallbladder that is usually caused by an obstructing gallstone. Gallstones produce disease states including acute calculous cholecystitis that vary considerably in their severity, clinical presentation, and management strategies. Prevalence increases with age and with increasing body mass index. There is a mnemonic being used, the 6 Fs: female, fetus, flatus, but that probably doesn't really apply for cholecystitis. The reason why I bring this up is because there is a greater preponderance for people with an increased BMI to get cholecystitis due to obesity. Also, females, people who are assigned female at birth, tend to have an increased predilection for the development of cholecystitis. Bariatric surgery is also a risk factor for the development of gallstones, primarily because this surgery is often performed in patients who are obese. The vast majority of gallstones are asymptomatic. They may be discovered incidentally on diagnostic imaging performed for a different purpose. Biliary colic is the most common complication of gallstone disease, colic again being intermittent kind of pain. Patients experience recurrent attacks of steady upper abdominal pain, typically radiating to the right upper quadrant, that typically lasts no more than a few hours and resolves spontaneously when the gallstone moves from its obstructing position. If the obstructing stone remains in place, acute cholecystitis may develop over time as the gallbladder becomes distended, inflamed, and in some cases infected. As acute cholecystitis evolves, it may result in necrosis and gangrene of the gallbladder wall, also known as gangrenous cholecystitis. Emphysematos cholecystitis, from the term emphysema, occurs when the inflamed gallbladder becomes infected with gas-producing organisms. Therefore, on imaging, you will see free gas around the border of the gallbladder. Gallbladder perforation is uncommon, but it is life-threatening. You can also see air on imaging with this. Gangrenous cholecystitis, emphysematous cholecystitis, and gallbladder perforation may occur with or without the presence of gallstones. Choledocholithiasis, which is a gallstone in the common bile duct. Gallstones from within the common bile duct may either be primary, which is they arise from within the bile ducts themselves, or more commonly secondary, forming in the gallbladder and then migrating to the common bile duct. Choledocholithiasis or other causes of common bile duct obstruction, such as strictures or tumors, may be complicated by cholangitis, an infection of the biliary tree. Chronic cholecystitis is a state of prolonged gallbladder inflammation typically caused by recurrent episodes of cystic duct obstruction by gallstones. Fibrotic thickening of the gallbladder wall develops. Biliary sludge is microlithiasis composed of cholesterol crystals, calcium bilirubinate pigment, and other calcium salts. It may be seen on CT or ultrasound. The clinical course of biliary sludge is variable. It may resolve spontaneously or progress to cause complications including biliary colic, cholecystitis, cholangitis, or pancreatitis. That being said, there are gallstone types, two major types: cholesterol stones and pigment stones. Cholesterol stones often have cholesterol monohydrate crystals. They occur in around 80% of patients. This is on a worldwide scale. However, pigment stones are more common in Asians. Cholesterol stones tend to be radiolucent, so they're a little harder to find on x-rays. Typically, you see them in obese, female, elderly patients, and those who have rapid weight loss. Pigment stones can either be black or brown, sometimes yellow, but mostly black or brown. Black pigment stones are composed of calcium bilirubinate. Brown pigment stones have a mixed composition. Usually they occur in the setting of bacterial or helminthic infection of the bile. They're radiopaque, so it's easier to detect them. And for black pigment stones, these are more common in patients with chronic liver disease or hemolytic disease. And brown pigment stones are more common in patients with bile duct stasis, such as sclerosing cholangitis and strictures. It's more common in Asia, just like I mentioned. Acute calculous cholecystitis occurs in the absence of any gallstones. It is much less common than calculous cholecystitis, but it may result in more complications. It tends to occur in the setting of critical illness such as septic shock, burns, and major trauma or surgery. Old age, diabetes, and immunosuppression are also risk factors. Bile is produced by hepatocytes and transported via the biliary system to the small intestine, where bile acids are necessary for the digestion and absorption of lipids. Bile is also the vehicle for eliminating a number of substances from the body, including bile pigments such as bilirubin, cholesterol, and some drugs. Bile is stored and concentrated in the gallbladder. When a meal is eaten, the gallbladder is provoked to contract by cholecystokinin and neural stimulation, resulting in the expulsion of bile into the cystic duct and then into the common bile duct, where it reaches the duodenum at the sphincter of Oddi. Gallstone formation is a multifactorial process that involves supersaturation of bile components, crystal nucleation, and gallbladder dysmotility. Gallstones are classified based on their composition into either pigment stones or cholesterol stones, which we have already discussed earlier. Non-obstructing gallstones do not usually cause symptoms. As gallstones migrate through the biliary tree, they can obstruct the gallbladder neck, the cystic duct, or the common bile duct. The resultant distension and increased intraluminal pressure cause pain, nausea, and vomiting. Symptoms are relieved if the gallstone returns to a non-obstructing position within the gallbladder lumen or if it passes through the biliary tree into the duodenum. If the obstruction does not resolve, inflammation results from a process that includes mechanical distension of both the ducts and the gallbladder, ischemia due to a interference in the normal blood flow, and inflammatory mediators including prostaglandins. Interestingly, gallbladder outlet obstruction being the inciting event in acute cholecystitis has been recently challenged. Although there are cases of cholecystitis that are completely abacterial, bile cultures are positive in around half of patients with acute cholecystitis. Typical culprits include gram-negative organisms such as Escherichia coli, Klebsiella, although gram-positive bacteria such as Streptococcus, Enterococcus, and anaerobic bacteria such as Clostridia and Bacteroides may also occur. It's also common to have multiple bacterial infections in the gallbladder. Biliary colic presents with pain in the epigastrium when it is not yet localized via somatic pain sensors and still visceral pain, or in the right upper quadrant of the abdomen radiating to the back once somatic pain receptors, myelinated fibers, are stimulated. Despite its name, the pain of biliary colic is more often described as steady, which is why I defined colic earlier, because colic is usually intermittent, but biliary colic tends to be steady. This pain is often accompanied by nausea and vomiting. Its association with food intake is variable. That being said, fatty food intolerance is not a reliable predictor of gallstone presence. Biliary colic demonstrates significant circadian periodicity, with a peak in symptom occurrence around midnight. Symptoms of biliary colic typically last a few hours or less. If pain persists for longer, gallstone complications of greater severity, such as acute cholecystitis or cholangitis, must be considered. In acute cholecystitis, pain becomes more localized to the upper right quadrant and increases in severity as peritoneal irritation occurs. Mild right upper quadrant tenderness without peritoneal signs is present in patients with biliary colic, but in acute cholecystitis, the tenderness is more severe and occasionally this may be accompanied by rigidity or rebound tenderness. Murphy's sign, which is the sudden cessation of deep inspiration due to pain when examining fingers reach the inflamed gallbladder upon palpation of the right subcostal region, is 65% sensitive and 87% specific for acute cholecystitis. Patients with biliary colic are afebrile. However, fever is classically described in acute cholecystitis despite only being present in about a third of cases. Jaundice is rarely seen in acute cholecystitis. Jaundice in the setting of biliary tract stone disease implies an obstruction of the common bile duct from choledocholithiasis or extrinsic compression of the bile duct by an impacted cystic duct or gallbladder stone or adjacent inflammation, also known as Miritzi syndrome. Gallstones can easily be established with radiographic studies, especially in our setting where pigment stones are more common. The classic presentation of cholangitis is Charcot's triad: fever, right upper quadrant abdominal pain, and jaundice, although, as mentioned, fever is only present in about a third of cases. And the entire triad is present in slightly more than half of cases. Most patients will have a fever and right upper quadrant pain, the presence of jaundice being less common depending on how far up the common bile duct the obstruction occurs. But generally speaking, if it's just the cystic duct that is obstructed by the gallstone, it's unlikely to see jaundice since the intrahepatic bile duct isn't affected in any way, and there could still be drainage of bile pigments and such. Raynaud's pentad, on the other hand, adds altered mental status and shock to Charcot's triad. It is seen in less than 10% of patients with cholangitis. The differential diagnosis of acute cholecystitis includes other diseases of the biliary tract such as biliary colic, choledocholithiasis, and cholangitis, and other conditions of the gastrointestinal tract such as pancreatitis, hepatitis, peptic ulcer disease, gastritis, and functional dyspepsia. Appendicitis may occasionally present with right upper quadrant pain. Chest disease such as pneumonia, pleurisy, or pulmonary embolism may present with pain of the upper abdomen. Diagnostic criteria for acute cholecystitis. Of course, you have to exclude acute hepatitis, chronic cholecystitis, and other acute abdominal disorders first. Local signs include Murphy's sign, which again is the sudden cessation of deep inspiration due to pain when examining fingers reach the inflamed gallbladder, usually on palpation of the right subcostal region. You can also have a right upper quadrant mass, pain, or tenderness. Systemic signs include fever, elevated CRP, but again, CRP is a non-specific inflammatory marker, so it could be elevated in other disease etiologies, and an elevated white blood count, which generally is an inflammatory response as well. Imaging, this goes without saying. Pigment stones tend to be radio-opaque, they're easy to spot. When it comes to diagnosis, it's suspected when there is one local sign and one systemic sign, and definite when there is one local sign, one systemic sign, and imaging findings of acute cholecystitis. Laboratory tests, apart from an increased leukocyte count and an increase in CRP, tend to be typically normal in biliary colic. Leukocytosis may be seen in acute cholecystitis, but its absence does not exclude the diagnosis. Liver function tests, including bilirubin, alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and gamma-glutamyl transpeptidase, are often normal during acute cholecystitis. They are more likely to be elevated in the setting of choledocholithiasis or other causes of bile duct obstruction. Abnormal gamma-glutamyl transpeptidase is the most sensitive and specific serum marker of choledocholithiasis. Marked elevations greater than 1,000 IU per liter of alanine aminotransferase or aspartate aminotransferase can occur in the setting of choledocholithiasis, but is more suggestive of a hepatocellular necrotic process. Generally speaking, there's not much value in radiography of the abdomen here. Abdominal ultrasound, however, is the imaging modality of choice for acute cholecystitis. Generally speaking, you can easily see gallstones here, and you can elicit tenderness with placement of the ultrasound. Sonographic Murphy's sign, maximal tenderness over a sonographically identified gallbladder, is particularly more important in the diagnosis of cholecystitis using ultrasound. The presence of gallstones and the sonographic Murphy's sign has a positive predictive value of 92% for acute cholecystitis. When there is an absence of both factors, it has a negative predictive value of 95%. Gallbladder wall thickening, pericholecystic fluid are relatively nonspecific for cholecystitis and may occur instead from ascites, heart failure, liver disease, or pancreatitis. When it comes to hyperechoic gallstones, you could also see posterior acoustic shadowing, especially with movement, it follows the stone. Acute cholecystitis may also be demonstrated on IV contrast-enhanced abdominal CT. However, it's generally poorer sensitivity and specificity, so ultrasound is still preferred. It also is unable to detect a Murphy sign. Choledocolithiasis is difficult to exclude with ultrasound or CT scan. Ultrasound fails to visualize the entire extrahepatic biliary tree in many patients and has a sensitivity for choledocolithiasis of about only 60%. Although CT is also limited by its inability to detect poorly calcified stones, it performs somewhat better than ultrasound in this particular disease process. Normal common bile duct diameter is less than 5 millimeters, although diameter is increased in patients with prior cholecystectomy and in the elderly. On ultrasound, you could see sonographic Murphy's sign on acute cholecystitis, gallbladder wall thickening of greater than 3 millimeters, pericholecystic fluid, and gallbladder distension on the short axis of greater than 14 millimeters. It's the preferred initial imaging test. On CT scan, gallbladder wall thickening may be more than 3 millimeters, pericholecystic fluid, pericholecystic fat stranding, hyperdense gallbladder wall, and gallbladder distension. Generally speaking, when fat stranding occurs, especially on the gastrointestinal organs and its accessory organs, this is usually indicative of inflammation. On MRI or MRCP, gallbladder wall may be thickened to greater than 3 millimeters. You may also see pericholecystic fluid, pericholecystic fat signal changes, and gallbladder distension, again, greater than 40 millimeters on the short axis. Asymptomatic gallstones do not require any treatment. Elective cholecystectomy is occasionally recommended for those at high risk for gallstone complications, such as those with sickle cell disease, patients with a planned organ transplantation, or those belonging to ethnic groups at a high risk for gallbladder cancer. Biliary colic management on the emergency room includes symptom control and referral to a general surgeon for outpatient laparoscopic cholecystectomy. Generally speaking, you give antiemetics and analgesics. Non-steroidal anti-inflammatory drugs are first-line therapy. The analgesic efficacy of parenteral non-steroidal anti-inflammatory drugs is comparable to that of opioids in biliary colic. NSAIDs also decrease the frequency of short-term gallstone complications such as cholecystitis. All opioids cause some degree of sphincter of Oddi spasm and an increase in biliary pressure, which is why even if they are required for pain control, they're not as recommended as non-steroidal anti-inflammatory drugs. Acute cholecystitis and its complications are managed in the hospital with surgical consultation. Early laparoscopic cholecystectomy is often the treatment of choice. Cholangitis can be life-threatening and demands aggressive care, including generous fluid resuscitation, timely antibiotics, and early biliary decompression. Endoscopic retrograde cholangiopancreatography is the decompression procedure of choice in most instances, and when cholangitis is suspected, emergency consultation with a gastrointestinal surgeon or gastroenterologist is needed. Percutaneous or surgical drainage is an alternative when endoscopic retrograde cholangiopancreatography is not feasible or if it is unsuccessful. Appropriate antibiotic regimens include second and third generation cephalosporins, carbapenems, beta-lactam and beta-lactamase inhibitor combinations, or the combination of metronidazole and the fluoroquinolone. However, it's generally not used for mild acute cholecystitis, just for cholangitis and more severe cholecystitis. Emphysematos cholecystitis is characterized by gas in the gallbladder wall or lumen resulting from infection with gas-producing organisms such as Clostridium species, E. coli, and Klebsiella species. It is associated with underlying diabetes and is more common in older patients. Its association with gallstones is variable. Gas occupying the gallbladder may be seen on plain X-rays, ultrasound, or more reliably intravenous contrast-enhanced CT. Emphysematos cholecystitis is notable for a 15% mortality, which is much higher than the mortality rate in uncomplicated cholecystitis. Gallstone Illness is a mechanical small bowel obstruction caused by an ectopic gallstone that has reached the intestinal lumen via a biliary enteric fistula. Such a fistula may occur in the setting of inflammation secondary to cholecystitis. Gallstone ileus may be diagnosed on plain films of the abdomen or more dependably with CT scan. The classic radiographic appearance is regular striad, a small bowel obstruction, pneumobilia, and an ectopic gallstone. Acute cholecystitis represents a very small minority of cholecystitis cases and generally occurs in the inpatient setting among patients with critical illness. However, it's usually also seen in immunocompromised patients. Clinical presentation is variable and there is no pathognomonic test result. Acute cholecystitis runs a more fulminant course than cholecystitis associated with gallstones. Chronic cholecystitis is a gallbladder inflammation and scarring that occurs over time, usually secondary to intermittent cystic duct obstruction. It presents in a manner similar to biliary colic or acute cholecystitis, although symptoms and examination findings may be more subtle. Patients may report recurrent episodes of pain. And post-cholecystectomy syndrome refers to a heterogeneous group of disorders that present with persistent abdominal symptoms after removal of the gallbladder. In the early post-cholecystectomy period, bile leak is of principal notice. Choledocholithiasis is a common cause of post-cholecystectomy pain. Symptom-producing common bile duct stones may be retained, that is present at the time of surgery, or may develop post-operatively, formed primarily in the bile ducts, often in the setting of bile stasis. Post-cholecystectomy syndrome may result from non-biliary pain that was erroneously attributed to a biliary cause and therefore may not be remedied by cholecystectomy.